So let's start off with a case of protrusio. Dr. Beausoleil, let's start off with exposure. Give me one pearl if you're doing as you tackle this job. Let's start off with what approach are you going to use?
For this case, first thing, you cannot dislocate easily. You need to cut the neck.
Okay, okay, good. So you're doing a posterior approach?
Posterior approach.
Okay, and you want to do
But I use a dual approach here, where I can expose the neck for safe neck resection. So posterior approach, and you can resect the neck, and then you get mobility, and then it is. And you have to be very careful. The sciatic nerve comes very close to trochanter. So take care, go along the bone and protect the sciatic nerve and soft tissues. Go along the bone.
Very good. So we talked about the posterior approach. We talked about doing an inside to neck cut. And you talked about the sciatic nerve being close to the bone because of the proximity. So Dr. Jain, give me an example of what you can do during your exposure to make sure that you're not anywhere near the sciatic nerve.
So you're not close to the sciatic nerve. Usually in these patients, the sciatic nerve is very close to the femur. So you have to be very careful. So you have to be, if you're cutting the rotators, you need to be on the bone, and your cautery or the knife should be pointing towards the bone. You should feel it. Okay, so I guess my question is, what technique could you use to make sure you know the difference between the femoral neck and the acetabulum? I'm sorry, you're Dr. Okay. So what technique could you use to determine whether you're on the femoral neck or the acetabulum?
So, I always do my cases in anterolateral approach.
Okay.
So in this anterolateral approach, when you open, you will be able to delineate the trochanter and the neck where I put a Homans. I put a gentle Homan, and if any doubt, I'll put a Steinman pin in that position and just take a C-arm shot, and to know that I'm exactly where I am. That is one. And then when you're doing a neck cut, in situ neck cut, you have to angle the blade in such a way that you are not tilting the blade towards the pelvic region. So
sure.
That is.
So I think your point of you can always take an intraoperative image to make sure where you are. Harish, do you have any suggestions of, if you're doing a posterior approach and you're trying to determine whether you're on the femoral neck or you're on the acetabulum, what can you do to make sure you know where you are?
In these patients, normally I like to go a little distal, isolate the sciatic nerve, come proximally dissecting it, and you can easily see that below the sciatic nerve is going to be whatever remaining of your posterior rotator flap is there.
So I think you're making a wide exposure. These aren't cases for MIS surgery,
and
right?
Yeah, and second thing is this patient, though it looks very stiff, usually they have some amount of uniaxial flexion movement.
Yes.
They may not have any adduction, abduction or rotation.
So
when I can identify the movement of the bone.
Excellent. That's what I was looking for. You have your assistant or someone move the bone, and if it's moving, it's the femoral neck, and if it's not moving, it's the acetabulum. Right? So if you're going down, you better make sure you're on the femoral neck. You're not going deeper into the notch. So any other, prior to, so now we've identified the femoral neck, we've identified the acetabulum, and prior to doing an in situ neck cut, are there any things that you could do to dislocate this hip?
Well, I normally try to do a dual approach as described. I've seen the CSR doing it, Dr. Ranawat doing it. We go in the front, identify the anterior part of a neck, expose up to the tip of the acetabulum, and then it is relatively easy to make it more because your anterior capsule is quite tight, and that prevents your rotation and movement. I may not be able to dislocate it. I most likely have to cut it in situ. And
so give me another suggestion as to what you could do.
May you tilt the table a little forward so you can see in a better way.
Okay.
And then once you've identified that, there should not be an issue.
Anybody have any other pearls?
You can put traction on the leg, and you
can
hook and lift it laterally and see.
Sure.
Let's see if it'll lateralize.
Anybody want to take any part of the posterior wall?
Yeah. Or the osteophytes, you just remove all around, if we can.
Exactly. So I think you take about a half a centimeter or so of posterior wall. That gives you a lot of exposure to the neck. It makes even just cutting the neck easier, and or sometimes that allows you to dislocate the hip.
Yeah, usually they've got big osteophytes, so taking some of that posterior wall is fine. This one looks more like it's a traumatic protrusio, so I don't know that you'll have those osteophytes.
This looks like a post-traumatic with the posterior column with the wall fracture.
Yeah.
The anterior wall is intact.
So now when you're doing the socket in these cases, what's your goal in terms of medialization?
The most important is the periphery of the socket is usually intact. So you have to widen, many times it is constricted, so you have to widen the mouth and carefully ream the deeper part, just scrape out all the soft tissue. The bony margin is seen, so there is no soft tissue, there is some, try to preserve that, don't break that, and that's the best way to ream, and mouth opening is more important, and don't go too deep, very careful to preserve the medial wall.
Does anybody have a technique to clean up the bone medially?
Not technique. I mean, I wanted to mention about how deep you need to go and how superficially you have to come. The dimension of the acetabulum decided here mainly by anteroposterior
Correct.
distance between the wall, anterior wall, and a posterior column and anterior column. Once I get rough dimension, I don't expand it. I just gently go superiorly, and I just see how my trial cup fits. Whatever is deeper to that, I have to fill it up with a bone graft. And the head which is there,
And where are you getting the bone graft from?
the head which is there, which I just cut at the neck, that's the best one I can get. I mean, it's probably will same shape as the defect is there.
All right,
So,
the rest of the panelists. yeah.
So if it's a post-traumatic, I would like to see if the patient has an X-ray when the trauma has happened, one, and maybe also the CT scan, because you may have some defect on the table, then you will not be able to handle it before you put the socket.
Absolutely.
This patient must be having a posterior wall as well as the posterior column, some kind of defect looking at the X-ray. And we'll have a CT done before.
So what I'm looking for, I agree with all those statements. Better imaging, false profile, CT scan could all be extremely helpful. I'm talking about, though, now you have the hip dislocated. What can you do to clean up the bone immediately before you put your bone graft in there? Go ahead.
So, sorry. So, reaming should be done only for the periphery, not to the deepest part.
Right.
And the deepest part is cleaned only with the curette, so that you get all the soft tissues out, but not the bone. And then fill that up with a cancellous bone graft or the bone taken actually from the femoral head without reaming the deepest part.
So I think the point of using a curette and using non-reamers is fine. I think if you use a reamer, you want to use a very small one, right? So you can go down to the medial and clean it out. But you're absolutely correct. You don't want to use the size that you're going to ream peripherally. You want to create that sort of double bubble, right?
So you got to establish a brush, so I think you can clean it well.
Many time there's a soft tissue like cartilage. So best before curating, you cut with the knife and then scrape it better with a scoop.
With the cautery, that makes really.
All right, great. What are the challenges in, once you put the cup in the anatomic position, and depending how long this hip has stayed this way, what are the challenges?
Big risk here is that the pelvis is your cup's going to fall into the pelvis, and 6 months later you'll be looking at a cup that's vertical and all the way in. So the trick is to get the stability of that cup on your peripheral bone.
Yes.
You want to create that a double bubble, as you said. So I'd go straight to my final reamer and be very careful about not reaming too deep. And you want to leave that shoulder between the bigger diameter and the smaller diameter on the inside. And you definitely want to be using screws.
Yep.
The comments have been made about the posterior column, and a CT scan would be helpful, but if it's healed, you may be able to get a rim fit with the posterior column, but if it's still fractured, you might need a plate or, other fixation for your cup.
Absolutely.
I need to also check that the host bone contact to the implant which I'm going to put has to be at least 60 to 70%. Because if I put excessive bone grafting medially and I don't have much of a direct host to bone contact, I may have to use something like a cage.
Those are all things that you need to consider. Generally speaking, however, that femoral head will fill up that defect perfectly, because that's what made the defect, right?
One more thing.
Question?
Yeah, one important point is the cup placement. Try to make it little horizontal so all the forces goes on the roof, not on the medial side. So instead of 45, make it 40 or slightly more inclined, 40 or 38 or 30. So that is better, so that the forces are more upward rather than medial.
Yeah, I think that's more, you need to have that bony rim support. If you don't achieve that, I don't care what angle it is, it's not gonna work.
The idea that the center of rotation has to get into the right position, then everything falls.
Right, so, I mean, I think the challenge, however, is you put the cup where you like it, and but you have a hard time reducing your hip now.
Just
Right.
one more additional point on this is what kind of cup you put. For example, some cups are hemispherical, some of them have peripheral, wider than the hemispherical like a PSL. So I think, in these kind of cases, I think we need to have that peripheral, the larger diameter like a PSL cup rather than hemispherical cup, which will have more hold on the rim rather than inside.
I'm not sure you need that type of cup as you're describing, but you need to create that ridge in the rim to accept that.
It's all in the reaming.
Yeah, it's all in the rim.
And I think that this is the case where you want a revision type acetabular component, right? You want,
Yeah,
you want a
multi-holes.
highly porous.
Right.
It's basically highly
multi-hole cup.
porous.
Absolutely, absolutely. Okay, we beat that one down. So here's a reconstruction option, and they use cement in the femur.
Amar, do you want to just talk a little bit about reduction of that hip?
Yeah, so
Like, these ones are hard to get reduced afterwards, especially if they've been in like that for a long time.
They're very hard to get reduced, and sometimes you have to put the stem down further. I think that's one reason why using cement can be very helpful. You can see they have the stem almost at the level of the lesser troch, right? So that's probably not where you would put the stem in a normal hip replacement. So yeah, I mean, I think there are extreme challenges. You have to release all the soft tissues all the way around the hip just to get the hip to reduce. So these are extremely challenging cases.
These are the
protrusio.
cases where you need that short neck collared stems, where it's easy to reduce with a low offset.
Absolutely.
And also it is a balance between the cup placement and the stem. You cannot lateralize too much, or you cannot medialize, leave it medial. So it has to be the right position, and using an intraoperative C-arm to make sure before putting the original cup. And also always better to add screws in the highly porous cup.
Yes. So screw fixation, we all agree with, and I think your point of this is a case where you don't want to lateralize, right? I'd rather have it a few millimeters medialized than a few millimeters lateralized, right? That I think is more important than the angle of the cup position.
Amar, can I?
Yeah.
Just a minute. If you can't see the neck during the exposure, there is, because I was trained with my boss and the Chandler era, trochanteric osteotomy is an excellent option to go anterior and posterior, which that
absolutely.
is one thing important. And
Yeah.
you should not forget the statement of Ranawat 1982 or 1984 for rheumatoid patient. Normal center of rotation, medial wall strengthening, and you have to lateralize the cup rather than the medialized cup. And he is the person who showed all world how to put the cups of protrusio, if you can look at the article.
Yeah. So you have to know sort of the Ranawat triangle and know where the acetabulum is supposed to be. And for the interest of time, we won't go through all that, but let's talk about acute acetabular fractures. All right? So and we're going to talk about doing a total hip in the presence of an acute acetabular fracture. So let's start at the far end. Give me some pearls. How are you going to tackle this problem if you want to do a total hip in the setting of an acute acetabular fracture?
Yeah, this case has an anterior wall plus medial wall fracture. The posterior wall is intact and the posterior column is intact. So there is an anterior defect, I expect. If the CT is there, it will be helpful. If I am trying to get the rim fit and get the screws proximally as well as into the inferiorly, if possible, to the pubis. That kind of cup, if I use, that is possible. In an elderly patient, I try to do this. With the same kind of fracture, if it is both anterior column as well as the anterior wall fracture, I'll try to do a anterior wall plating.
Right. So I think all the points you made were excellent. Getting proper imaging, doing a rim fit again, that's what you're seeking. So you could tackle this as a full-on fracture and try to repair everything, but what are you going to talk to your trauma surgeons about if you're thinking of doing a total hip replacement?
Basically, I do this pelvis acetabulum also, so I fix the anterior column and put a plate.
Yeah, so my point is that you can do a plate that is not designed to completely, you don't have to go all the way to the pubis. You can do a minimal plating of the anterior column just to maintain stability because you're going to be putting in a socket, right?
Yes.
So I think working with your traumatologist and making them understand
I want.
what you need in order to get your acetabular stability.
Correct.
Amar, we need to understand what is the indication of total hip in acute acetabular fracture. Because so there's very defined indications, like patient has an osteoarthritis or arthritis before, or patient has apart from the acetabular fracture next same time.
Absolutely.
Otherwise, you have to be very careful doing an total hip and acute acetabular fracture.
Age and the physical.
Yes.
100%, 100%. Well, give me some other reasons now. All the things you mentioned are correct. Give me some other reasons you might consider doing a total hip replacement. You mentioned femoral neck fracture. What other injuries to the femoral head could be involved? Yeah.
So,
Right. So,
intra-articular damage to the femur, if you see the head of the femur is deformed, and elderly patient, of course.
Sure.
If it is intact, I think fixation gives a good result.
but Pipkin fractures, Contra-Coup fractures, all of these types of other fractures could lead you to go to a subfracture.
And a very thin posterior wall.
Yeah.
For example, it's going to definitely fail within few months, and if we anticipate that, I think it's the indication for a primary. Because the dislocated hip posterior wall for a few months is going to end up with a total hip anyway.
So the other option is to fix the fracture in the pelvis and wait for them to develop arthritis and then do the hip replacement. And I think where I'm from, that used to be more common, and now they're more commonly going in and fixing them acutely. Is that what you're seeing?
Yeah, I think, I've seen that happen. I've seen people be put in traction for 6 weeks, right, and have the hip sort of more or less reduced. And so there are a variety of strategies. I mean, I think in India, what I've seen a lot is that's what happens. They're not put in traction by the surgeon, they're put in traction by their family members. Like they're left in bed basically for, several months, and then they still can't walk, and then they come to the doctor, with a healed or fibrous union.
The first case.
Yeah, exactly.
But in general, I think they have more complications than you wait for some time and then have a total hip replacement done. That's what I think. In terms of dislocations and perioperative complications.
If this is an acute case, I try to fix the acetabulum and put the patient on non-weight bearing for 6 weeks.
Yeah, if it's a healthy person and a younger person, all those things, right? So again, just demonstrating the complexity of the situation, right? Multi-screws, trying to get stability. So these are complicated cases. If you can avoid doing a total hip in an acute acetabular fracture, that's probably the thing that you should try to do, right? Fix it, put them in traction, and try to fix it later.
One point, in multi-hole, the recent trend is if you put one screw in pubis and ischium, it really adds to the stability.
100%. I think it's a challenge. So who wants to talk about how you put a screw into the pubis and the ischium? All right, go ahead.
So, I mean, for this particular patient, I would have put at least an anterior column screw, so that the anterior column becomes stronger, stable, and the reduction of the fracture in a acetabular fracture, if you are going for a total hip replacement, is not that important. What's important is trying to get some stability of the column.
Correct.
So that we have that one. And the second thing is the question what you asked is the most difficult part is putting that pubis screw. It's the guys who tried it's very difficult to do that because the orientation of the holes in this multi-hole cup and a lot of these cups will not let us do that easily. So one of the method we do is we put a K wire, even before putting the cup inside into either to the superior pubic rami or even the ischium, then thread the cup into the K wire and then go in the same hole. Even then it's quite difficult.
If the cup doesn't have screw in direction with the either anterior column or the pubis or ischium, how the threaded K wire will allow you, that cup to go and settle on the bottom? It just stop at some point.
Yeah, no,
So these are, I think, this is a peripheral, revision type of a screw with the peripheral holes.
Yes.
And then you can have some peripheral screw in addition to the screw put inside.
So the cup cage construct is not available with most of the companies, but that was one of the great options available for these fractures.
But I think the point that I was trying to bring out, which you mentioned, is you pre-drill or pre-pin the pubis, and the same thing could be held true for the ischium. You can cut the wire, right? You can get the cup that goes right over that little wire tip, and now you know, because that's the screw you have to work on. The other screws, you right? Then you get the cup and take the wire out, put the screw in through that hole.
So the point is, before putting the cup, isolate the wire in the pubis and this thing, and then relocate the hole on those wires.
Exactly.
If you do that kind of thing, you will lose the version and the inclination of the cup. So if at all, if you want to put a screw in the pubis, you get a T-Mars cup kind of thing and use a cemented cup.
Yeah, so you cement the liner, right? Yeah, so it's you're getting fixation first. You're not worried about positioning as much, and then you're going to cement your liner in whatever position, or cement a dual mobility liner, or et cetera. Yeah, it's basically saying that acute acetabulum fracture treatment with total hip replacement is more complicated than total hip alone. And all the complications are much higher in these very complicated situations. All right, so post-acetabular fracture, the fracture is healed. Now it's developed post-traumatic arthritis. Let's go through, starting from the far side. How are you going to tackle this hip replacement?
In this case, I like to have a CT scan to find out what are all the screws which are in maybe affecting my cup, reaming while reaming.
All right, who wants to get a CT scan and know where the screws are going to be?
So I'm going to say I'm going to get a CT scan because of the way I do hip replacements, but you don't really need it because I'm just going to remove the screws that I come in
That are in your
contact with.
Yeah.
Right.
And how with what? How are you going to do that?
I'll use a metal cutting burr
Right.
from inside to get those out. This is one where I would do limited removal of hardware. Just one word of caution here, you need to work these patients up for infection before you do their hip because some of them will have an occult infection.
Absolutely.
Two things basically. One is the infection. Second, the higher sciatic nerve palsy, and also the more chances of HO in these kind of cases. I don't do CT because we can see the most of the column is intact, and
it's not the wrong thing to get a CT scan, but I'm not sure how much it's gonna.
the thing is we remove the metal only what comes in the way.
Right. That's the point. Is you're not going to take all the hardware out through an ilioinguinal approach. You're going to just take out what you can see from
The
the
nerve problem comes only if you try to remove all the metal wear and then try to do a THR.
and the HO
Yeah.
and all those other problems comes from trying to remove all the hardware, right? So this is definitely a situation where you
This
don't
looks
want to.
like a bicolumnar fracture because there is a ilioinguinal plate and a posterior column plate.
Yeah.
And while fixing, there may be change in the orientation of acetabulum.
Absolutely.
So the CT scan is not to see the metal work where it is because I can anyway see it, but to see whether the edges of the acetabular cup, is it changed into less anteversion or a retroversion because of the previous surgery. The second problem is I will not try to remove any metal unless it comes in a way, but problem is I remove the head, try to start reaming, and then I see some screw going horizontally into my, the cup area. Just to remove that screw is, then I end up putting or may have to do something, either take that screw out by burr or I have to remove the entire plate, which is a big procedure itself because these are a large plate put from the probably ilioinguinal approach, and maybe they have got a posterior approach.
One indication for the CT is to rule out pelvic discontinuity. That is the only thing, if at all, if you do a CT, because sometimes you might, in this okay, but some cases there will be maybe a union or not united, a fibrous union.
Again, I'm not saying it's wrong to get the CT scan. I'm saying, if there's any concern, get the CT scan.
Yes,
Sure.
but this patient also has the inferior pubic rami fracture, so I'm sure getting the right version is very important.
So the reason for CT, again, I want to know the posterior wall is how it looks. Depending upon that, you can choose your cup.
We just come from a different generation. I open the hip and I look at everything, and there's my CT scan. All right. So there's, they removed some of the screws, they got the cup in, and they did a non-cemented hip.
Fantastic.
Yep. And again, same thing. More complications in these cases, right? Higher rates of infection, dislocation, HO, as you guys all mentioned. I think all too often we look at x-rays and we go, oh, that's not so bad, right? And that's when you get into trouble, when you underestimate these cases. All right, intertrochanteric fracture and total hip. Tell me about some issues. Talk to me about exposure first.
Yeah, I think the indications are very precise. So elderly patient, communicated, and you want to make them walk early, and posterior approach is good. The issues are usually there is a lot of laxity and there is a very high instability issues. So you have to take care and dissect very carefully, and you can use, you need a high offset many times.
Just about
lateralization.
Keep going, yeah.
For me, the indication for a THR in these kind of fractures is if the patient is old age, and also an unstable fracture, like a type 3, type 4,
Yes.
where the posteromedial comminution is there, and we need to mobilize the patient early, so that is where the indication. So unstable fractures, comminuted old age, total hip, or even a modular bipolar with a short titanium distal loading stem, and then wire all the, with ethibond, wire the trochanteric comminution into the stem.
Is it fair to say you don't want to do total hip replacements in these fractures unless you,
Yes.
right?
Yeah.
Now, can I just
Sure.
so these are difficult ones and should
Yes.
be avoided, because a lot
Yes.
of people can have the dislocation with that, especially if you don't have an experience of fixing the trochanter properly. Approach for this can also be what Chanley described, because there is already a trochanteric fracture, so you can go through like a trochanteric osteotomy, direct lateral approach. You don't have to cut the posterior structures, you don't have to cut the anterior structures, because you are just inside the joint already because of the trochanteric fractures.
Excellent point.
So for most of the common orthopedic surgeons, if you try to do a THR on a trochanteric fractures, they are difficult, there are high chances of dislocation, etc., unless you know how to fix those trochanter very well.
So, Amar, apart from all those sets, but bad combination, but prior doing a total hip in OR, I would rather even see in the traction table and image how that's getting reduced.
Yeah.
If that's the case, I will definitely keep backup of my trauma things.
One important thing is when the trochanter is fractured, you can go, as Dr. Lard sir has showed us, you can go through the trochanteric approach without cutting the posterior capsule, open up the trochanter, remove the head, put the joint and close it. So there is a minimum risk of dislocation because the capsule is intact. So that's a wonderful approach. A lot of patients will do it and extremely happy. No dislocation because of the clipping of the bone without cutting the capsule.
So let's go and focus a little bit on the one with the hardware, right? So we have a failed ORF or cephalomedullary nail. Talk to me as far in. How are you going to walk through getting the hardware out?
See, this one, through the posterior approach, I go first remove the distal screw as well as the, I try to dislocate and remove the hardware completely.
Okay, so the point, I think you said it, but I want to make it clear to the audience. You're going to dislocate the hip first before you start taking the hardware out, right? I think that's the point I want to hammer home. Because you open up the hip and you're looking at the screws and you get all like, oh, let me start taking screws out. Dislocate the hip, release all the soft tissue adhesions, right? Put the hip back in, then start taking the screws out. So, Dave, give me some tricks on how to get the hip screw out.
So first of all, know the hardware that's in there.
That
Because
helps.
there are removal sets. That you can get some universal removal sets, but it's nice to have the right instruments there. Remember that there's a set screw that's locked, the lag screw.
Excellent.
So you've got to find the top. This one will be pretty easy because it's sticking out through the top of the trochanter. Sometimes they're harder to find. You can even use fluoro if you need to find that screw. Loosen up that set screw. Then you're going to take the lag screw out. Then sometimes you have to tighten the set screw again in order to get the extractor device in the top.
So you're talking about taking the lag screw out the way it was put in from, all right? Does anyone have any other techniques to get the lag screw out? Say you don't have the system that it comes with.
So usually when you have dislocated the hip, you try to cut the neck off. You can see the proximal end of the screw. You can just hammer that in.
Absolutely, it's great. So that's exactly what I want to see. You dislocate the hip, you cut the neck inferiorly, superiorly, you basically get the head all into pieces, and you can, with a rongeur, sometimes just pull it out, or you can hammer it from the bottom up, right? So you can take it out in a antegrade fashion.
So just one point, when you want to engage the extractor for these nail, you make sure that the distal screw is not removed before doing that, otherwise
Yes.
the nail keep moving inside. So engage it first and then remove the distal screw.
No, okay, so I thought you were saying, don't forget to take it out before you slap it out. But no, your point is to give yourself stability as you're putting it in. Yes,
Then remove it and then take it out. Otherwise, it just keeps moving inside.
I agree, that's a great pearl. I think too many people get too excited to remove the distal interlock, right? And it should be the last thing that you do, right? And as I said, that's kind of the challenge that we have when you open it up, you're looking right at it.